Welcome to the new Cyber Frontier, bringing you the latest news and initiatives that focus on the development of cybersecurity economics. You don't have to be a computer or cybersecurity expert to get plugged in. Your host brings it straightforward, asks the tough questions, and brings the cyber world to a level of understanding for everyone. You can find us on the web at www.newcyberfrontier.com. Now join our host as he introduces the topic for today's new Cyber Frontier.
Welcome to today's episode of New Cyber Frontier. On this episode for IEEE blockchain and AI, we're continuing that series. We have an international guest today joining us from Buenos Aires, Argentina. We have Diego Kaminker, who is the affiliate director for HL7 International and owns his own business, Kern IT, as well as Diego is also a fellow podcaster. So been on the air from Argentina. He operates a podcast exploring healthcare interoperability. Welcome today, Diego. Thanks for joining.
Thank you for having me here. Pleasure.
Definitely. Looks like it's getting dark there. Is that what I'm seeing where you're at?
Yes, it's getting dark. It's 8:20 in the afternoon. It's just getting dark because it's almost summer here. So it gets dark at 8-ish.
Yeah, you're in the opposite side of the world, so maybe I should come down there and get some summer because I'm just kind of entering into the winter months here.
This is the moment when you want to be here.
Uh-huh. I think, that would be optimum if I could spend the summers in North America and the winters down in South America. I think I would just love that.
Yes, you will lose the snow. But...
Yeah. I'm not too happy about the snow anymore. I'm here in Colorado, and people always brand Colorado as cold, but we're actually kind of in a desert. So when the sun's out, it's so clear that it's warm, or it's clear, so it's warm as soon as the sun's out. We just get the very big shift of temperature from day to night. As soon as the sun goes out, it gets cold. Atmosphere's thin, so the heat dissipates quick. But anyway, we get that kind of that back and forth. If it gets cloudy, it's cold, or if you go up in elevation, you also get the cold. But for the most part, I don't do too much elevation stuff anymore. But welcome. Tell us a little bit about yourself and how you got to where you're at.
Well, I began working in healthcare interoperability maybe 20 years ago, and I got involved because some big hospitals here want to integrate diverse systems into one big EHR. So one of the problems in healthcare is that systems are disjoint, and you need to use the patient as your interoperability vehicle. So you got your patient, and the patient has some papers, and the patient goes from one place to the other, and you are relying on the patient for information, and it's wrong. And it has been a long way from HL7 also try to solve this problem. And the problem doesn't end when you want to integrate things inside of a hospital, because you have a lot of systems in the hospital. You have billing, you have labs, you have imaging, you have the EHR, what the physicians use. You have the hospital system managing the beds. Imagine hundreds of systems, and they have to work together. And this is worse when you have two hospitals and they want to exchange information between them, or a hospital network, or 3 hospitals network, or a province, or a country, or when you want to go from one country to the other and you want the physician in the second country to see what they have done to you in the first country. And this may seem a little strange or odd, but now in COVID days, it's daily. We want to know who is immunized and who is not. We want to know who has antibodies and who is not.
Mm-hmm.
We want to know who was ill and who wasn't. And we want to know if you have any problems before entering a country.
Yeah.
So that was something in my day job, usually for the last 20 years, now is something that everyone wants to have.
Yeah. Let's take a
So-
break here. Hear from our sponsors. We'll be right back in a minute.
Blockframe Technology offers next-generation blockchain managed trust and security. Unique non-fungible tokens are used to secure software bills of materials to provide data quality and security for every transaction in your supply chain. Deploy advanced peer-to-peer product security, scale zero trust capability to millions of IoT devices, allow vendor tracking and accountability, and rapidly reset from compromise. Unchangeable, time-sequenced blockchain data provides next-generation security using machine learning trust algorithms and audit analytics. Start securing your supply chain today by contacting Blockframe at www.blockframetech.com.
Welcome back to New Cyber Frontier. On today with our international guest from Buenos Aires, Argentina, Diego Kaminker, who is the affiliate director of HL7 International. So before the break, you were talking about your progression of getting to what you work with daily, the hospitals, and I kind of wanted you to expound on HL7. Now, what is that, and what does that mean? Your role with what you're working with?
So HL7 is an organization that creates standards, and it creates standards for exchanging healthcare information. So we don't create the products that exchange information. The industry creates the products that exchange information. We are just the place where everybody sits in a table and discuss how this information will look like and what is needed. And mainly there are three dimensions. One is the structure of what you are exchanging. So it's an XML file, it's a JSON file, which are the elements in this JSON or XML that you want to exchange. And then there's something very important, which is called terminology. So some of these elements that you are exchanging are coded elements, like male and female, or gender, or yes or no for an answer.
Mm-hmm.
So how do you tell yes? You say yes, you say 1, you say 45. How do you say male? M or plus or 1 or 0?
Mm-hmm.
So this kind of stuff should be understood. And this is just the beginning. I'm just giving you very small examples. What happens with diagnosis? How do I define diabetes? What is the code for that? Who manage these codes? And the other issue is workflow. When are we exchanging this information? Because it's not the same doing it after the patient is gone than just in time, for instance. So the combination of workflow, structure, and terminology gives us the level of interoperability we are looking for. And I'm forgetting security,
Mm-hmm.
which it was not in our front interested usually, but I think because in the past, you were safe if you were inside of a hospital. Speaking about everything was wired. So if you didn't have access to the outside world when you were inside. But now that this has blown up, we don't have any security anywhere because you have your phone.
That
and you
sounded
can
really dangerous. That what you just said there. So the industry has moved on from wired inside the hospital to wireless across the internet, and still operates the same.
it is no. I'm not stating that it's the same. I'm stating that the healthcare industry in informatics is very slow,
Mm-hmm.
and it's changing, and we are getting these concepts in our standards as something that is also of interest. In the past, there was no mention about security. It was not that there was no security in the implementation. It was that it's not mentioned in the standard, and you have to do it on your own.
Gotcha.
What we are doing now is to getting that into the standard itself, trying to enforce it, or at least to recommend the use of certain techniques in the standard themselves.
So when we're looking at security, we're also talking about the hiding and the obfuscation or the concealing or the separation of data content within the record itself.
There are lots of regulations on that. One is called HIPAA in the States, and every country has its own regulation on that, but it's not part of our standard, it's other regulation.
Okay.
And some of the regulation, for instance, states that you need to encrypt your data at rest or in movement. So you need to have your information encrypted when it travels from one place to another, or even it forces you to encrypt your information when it is in your storage. Or maybe some of the countries mandate the separation of the demographic data of the patient from the clinical content. So you have to have a fake patient ID in the clinical content part, and in some place you relate the fake clinical ID with the actual ID, but they if they get the clinical data, they don't know who it belongs to. So and if you want to use this information for research, you need to de-identify your information, which means remove any kind of information that can tell you who the patient is exactly. And you may think that that should be only the patient identifier that the hospital uses, or the birth date, or the name of the patient, or maybe the driver license, but it's more deep than that. For instance, what happens if we share the zip code? You may tell me, okay, zip code is a lot of people lives in the same zip code, but not always. Maybe you are in a place where you are only 5 in a zip code, or 10. In my country, it happens. So it will be easy to know who is the person with 20 years in this zip code, and you can you can re-identify the patient. So there are a lot of stuff going on. It's not part of what we are focused on. We focus on the structure of the information, on the actual data that is exchanged. What is a patient? What are the attributes of a patient? What is a lab result?
So it sounds like there's a big piece of privacy in there too, where you're addressing when you talk about which pieces of information can be together, what has to be removed for a set. That's more about the privacy aspect.
There is a lot of work on that too, and there are ways. What we focus on is on getting some way to express these privacy concerns of patients, and the fact that they want to share some parts of the records for some uses, and they don't want to share other parts of the record for some other uses. For instance, you want to share all your information with your general practitioner, the physician that is in charge of your health usually, but you may want to not show these records to your specialist in nutrition, for instance, or maybe you have some mental issues or sexual issues, and you want to keep those out of scope for anyone but the physician that is treating you on those specific issues. So it's very difficult. And the other thing is that the privacy and the consent of the patient about the information may change in time. So you may not block or unblock the information forever. It's not part of the information itself, but is related to the information. I'm not sure if I explain myself correctly.
Yeah. Yeah, I think so. Let's break here. We're going to hear from our sponsors. Be right back. But this is interesting because a lot of people will understand the different pieces of the data, but the relations you're explaining are very valuable. Be right back.
Blockframe technology offers next-generation blockchain managed trust and security. Unique non-fungible tokens are used to secure software bills of materials to provide data quality and security for every transaction in your supply chain. Deploy advanced peer-to-peer product security, scale zero trust capability to millions of IoT devices, allow vendor tracking and accountability, and rapidly reset from compromise. Unchangeable, time-sequenced blockchain data provides next-generation security using machine learning trust algorithms and audit analytics. Start securing your supply chain today by contacting Blockframe at www.blockframetech.com.
Welcome back to New Cyber Frontier. On today with Diego Kaminker from Buenos Aires, Argentina. And before the break, we were talking about kind of the division of information in a health record, a digital health record, and all the pieces involved with it, and how that relates to individual privacy and the security of them was kind of where we were heading to. Now, I had a question, just thought about why we were on break. If we come look at all the different things that could go wrong with me, like medical conditions, are all of those conditions identified in with categories, or is there like textual information that goes into some places?
Well, that's a good question. There is a tension between text-based information and coded information, and depending on which country you are and with which is the custom of the practitioners, of the medical people, they used to just use text and no structure around the text. Or in some places you have a very powerful structure and guidelines on how to report. For instance, let's take radiology or pathology. If you have seen a radiology report or a pathology report, they have sections, and these sections have free text, but they also may have coded elements, because some parts of the report may include coded elements to make them easy to stratify. So, for instance, in anatomic pathology, you have the morphology and topology of the tumor, which is where it is located and what it looks like, or how pathogen is it. So there are some things that are better if they are discrete instead of putting text. And one of the areas of artificial intelligence that are involved into this is how to get this free text and transforming it into coded information. That's a very interesting area of research, because what evolved very well was the capability of speaking, and the computer will take your voice and transform that into text, speech to text. And that's okay, because it allows you to create text without writing, which is something the physicians appreciate a lot, especially the radiologists. But the other point is how to get this text into information. And that's a nice area for artificial intelligence too. I even saw a product that it will hear what the physician is discussing with the patient and will create a transcript for the physician. So the physician doesn't need to write what he's discussing or she's discussing with the patient. Because one of the problems of using EHRs is that the physician is looking at the screen instead of looking at the patient. And if you are in a physician visit, you want the physician to look at you and listen to you, and not looking to the computer. Even for me, I'm working on this, when I'm going to the physician, I want the physician to look at me.
Yeah. So is the effort to kind of eventually code everything and get away from text?
I think that that's a bad approach, and not because you speak about it, it's because I've seen it,
Mm-hmm.
and it creates a lot of resistance to change from the physician, and you want them to be able to express what they want to say.
And
If
and knowing all those categories sounds like a lot of administrative work they would have to do.
Yes, if you limit their ability to express themselves and only put the categories, you are losing information,
Mm-hmm.
because you need to record what the physician thinks about the patient.
Yeah.
It's very important.
So now if we look at the digestion of that information downstream, who uses it once the physician puts it in, it's more valuable downstream to have it categorized. Is that what I'm understanding? And that's why you want to have that translation?
Yes, the problem is that we want to count. We want to know what happens. We want to know how many patients has this disease and how many, and you've seen that in the COVID crisis. What is the most seen site in the world? The Johns Hopkins statistics about the COVID and how many cases in each country, etc. So we want to know how many of everything.
Mm-hmm.
So that's because we learn from that, and we base our policies on knowing how many people has this disease or the other and how many evolved correctly. And you may even be paid on how your population that you have in charge is evolving. So that's called a clinical measure. So in order to measure, it's not enough with text. You want to know if this patient has diabetes or not, and what is the value of the hemoglobin, like this date compared to the other months, to see if it's controlled. So values and discrete values are very important.
Mm-hmm.
So there is a tension, and you need both. You need the text, and you need some coded elements to succeed.
Yeah, it's like we have an opposition here, though, in the value of that data for everybody to see, because they want to know who has COVID, but yet the individual rights to privacy say that I have control over that. So how do you make that kind of cross? You know, a lot of the guests on this series have talked about using blockchain for that and the separation of those different aspects.
The problem is that the measures are on quantities.
Mm-hmm.
So we are not talking about you. It's about we had 100,000 patients on this disease, and 20% of them are good or they are improving or not. And I don't think this will impact in privacy. I think that individual records will, the sharing of individual records without permission or the misuse of individual records
Mm-hmm.
impact privacy. I think that grouped records for epidemiological reasons are part of what we need as a society to live.
Mm-hmm.
So if we don't know how many cases of each disease, we don't know if we want to treat them or not. So that's in interest of any state in the world to know how the population is. We cannot live in civilization if we don't have that. That's my own opinion.
So you think that's separate from the record, though? Because, I mean, if we had to examine 100,000 records to find out what percentage of them had COVID, we have to have access to 100,000 records.
That's correct.
And that's 100,000 people's privacy that you might be construed as violating.
It depends on how you implement it. Because if you ask the hospital to calculate its own measure on their records,
mm-hmm.
you don't need to have the actual records. Or if you send just you don't need the actual patient identification to have the condition counted. So you may send a de-identified patient with only the attributes you need to make this information useful. Like, for instance, instead of sending the birth date, you send just the year of birth. Because with the birth date and the gender and some other data, you can re-identify. So I understand your concern, but I think there are techniques that allows us to exchange the information for public health interest and still respect the privacy and the confidentiality of the record. The other way is to make the hospitals or providers to measure themselves. So you may exchange the measure and teach them how to measure. And there's a standard in H7 to define how to write the measures and how to calculate the measures, which is called CQL, clinical quality language.
Yeah.
So you can ask the hospital, okay, with your population, calculate this. And I don't need the actual individual data. I need the calculation. So that's one way. And the other way is to get the information de-identified and do the calculation. And if you are using the de-identify information, you are not breaking the patient confidentiality or safety. And the same happens. I'm working on a project of about adverse events of immunization. And you have to report any case of adverse events of immunizations, because we want to know if the vaccines are working or if they are causing any damage. But we don't need the actual name of the patient, or we just want to know where the patient were and which vaccine was used and what was the problem. So you can do public health without knowing the patient name and identifier. Yes, you can.
Yeah. Well, it's been an interesting talk. It's an area I'm not as familiar with, so you definitely have helped me. We'd looked at several times at the HL7 in terms of how does that mesh with some of the smart contracts and blockchain, how do you implement it into it. And I know that's not your area of expertise, so I won't bring any discussion in that area. But I think there's definitely a path here for using blockchain and integrating with this standard to say it's very modularizable into the ability to have that balance of protecting the information on one person's record in their control and only letting pieces of it out.
Even when I'm not an expert, I think that if the patient is in charge of the record, it may be useful. But in our industry worldwide, that's not always the case.
Yeah,
the record is managed by the provider. You have right to see the record. You have right to maybe prohibit the provider to share it. You have right to edit the record if you think something is wrong. And I'm talking about the law here, at least. So our law and several laws around the world about healthcare information. It's not that you are in charge of the record, because as a patient, you cannot make sure that the record is okay. You don't have the storage on your own to protect your record. The record is provided.
And that it's accurate as well.
Yes, you don't know, maybe. So you can sometimes you have the right to say to the provider, okay, this is wrong, and I want that to change, because this is not right about me.
Yeah.
That is your right. You can do that, and it's mandated.
Yeah.
And you can also tell the provider, I don't want you to share my information with no one. For instance, there's this tension usually in the shared EHR projects that I've been involved with on how to make the patient decide whether they want to be in the project or not. So you have this big shared EHR that you want any any provider, any physician in your country to see your record if you go from one physician to the other.
Yeah. Well, let's
So
we're kind of reaching the end of our time here, but I wanted to give you the opportunity to reach out to our audience and let them know how they can get involved with what you're doing. Give them the URL for your podcast so they can listen if they're interested, and any other things that you might want a shout out to go for our audience.
So the podcast is available in Spotify, and it's called Exploring Healthcare Interoperability. I'm sure you will find it and make it available for your listeners. We created 2 chapters so far. One about Ed Hammond, which is our one of the founders of HL7 25 years ago or 30, and he's working with me in the podcast. And the other one with some folks from Brazil. And we are planning to create more chapters as we go along with some other countries to see how they apply standards in their country to improve the sharing of healthcare records and healthcare as for the population.
All right. Well, thank you for joining today. It's been a pleasure, and you have a good one.
Thank you very much.
We hope you have enjoyed this episode of New Cyber Frontier. Remember to get involved. Often we think that someone else will handle privacy and security in the virtual world, but you are the only one truly in command of your virtual fate. Join our mailing list so we can keep you informed of breaking news and new releases. If you have an idea, if you have a question that you would like to hear answered, or if you want to get involved with our efforts, reach out to us at newcyberfrontier.com. We also encourage you to visit our sponsors' links, as they are the ones that really make this show possible. I want to thank each of you for supporting the show, and we look forward to seeing you back for the next episode of New Cyber Frontier.